Welcome to the Hollings Crosstalk. I'm Dr. Ray DuBois, Director of the Hollings Cancer Center. In this episode, we're going to be talking about the cancer that I've spent my career on, colorectal cancer. And we'll see a story of two patients diagnosed in their 30s, and we'll talk about things you can do to reduce your risk. Well, I want to welcome Dr. Thomas Curran, a colorectal surgeon here at Hollings.
Dr. DuBois, it's a real pleasure to be here and really excited to chat with you.
Well, we'll just jump right in. For colon and colorectal cancer, you know, the catchphrase is screening, and everybody's talking about that now because we really had a decrease in screening over the pandemic. Obviously, we're now recommending 45 instead of 50. Can you say a few things about why that change was made and why you think it's important?
I'd love to, Dr. DuBois. So it is the mantra over in our digestive disease center that 45 is the new 50. And so this is something that we've had this confluence of factors with the pandemic, as you mentioned, but things going on in the background despite that. So there was some really groundbreaking work done through the National Cancer Registries that was published in 2017 that really showed, despite the fantastic work we've been doing in screening, that cancers in younger patients, they demonstrated that 1 out of 3 new rectal cancers is in a person aged younger than 55 in the United States.
Wow.
And it's very fascinating that in the United Kingdom, in Australia, New Zealand, these same trends have been observed with patients younger and younger being diagnosed with colorectal cancer, and in particular, cancers in the rectum and the left side of the colon. And so in recognition of this, we've really tried to be more aggressive in screening patients younger, and that really is the origin of the 45 is the new 50.
Now, I think we probably should jump back and do a little anatomy lesson because we have lumped all of this into one thing, colorectal cancer, but as you know, the biology is different, the behavior of the diseases are different when you look at the colon separated from the rectum. And so maybe you could educate us a little bit about that. Even though we call it colorectal, it's really at least two different diseases.
Really, the colon and the rectum are both components of the large intestine, and that's the last roughly 3 to 5 feet of the digestive system. And you're exactly right that we've kind of used this umbrella term of colorectal cancer, even though at the biologic level, probably there are different mutations and different factors that contribute to the development of colon and rectal cancer. And the nice thing to kind of make our messaging a little more easy to handle for folks is that the screening, the management in many ways has a lot of overlap. So screening is just as effective for both, even though technically rectal cancer, roughly the last 6 inches of the GI tract, colon cancer, the remainder of the large intestine. But the screening strategies, the preventative strategies really go hand in hand.
And the treatment's a little bit different.
Correct, yeah. Rectal cancer, a little more nuanced, utilizing some of our colleagues in radiation oncology, medical oncology, and we're really fortunate here to have tremendous expertise in that at MUSC. We were recently recognized nationally as a center of excellence in rectal cancer care. So it's something fantastic. We're very proud of.
Yeah, that's great. And we've touched on a little bit about the benefit of colonoscopies. And, you know, I think one of the messages that is important for our patients is there are what we call premalignant lesions, adenomas. They're not cancers yet. And if we can pick those up and then remove them, then that really decreases the risk. Maybe you could say a few words about that and why you think that's important during the screening exam.
Absolutely. So a lot of people are really surprised to hear that the most common presenting symptom for colon and rectal cancer is no symptoms at all. So this is really why it's critically important that folks get screened. So with that, we know that polyps are little growths on the lining of the colon and rectum. Almost you can think of them like a freckle on the colon or rectum, that those over time, usually over a period of months to years, can develop into a cancer. And that's when they can really cause problems. And with colonoscopy and other screening tests, we have the ability to pick these up early so that they can be removed, and that colorectal cancer and, of course, deaths from colon and rectal cancer are prevented.
And, the other aspect of colonoscopy, and we've heard a lot about them in public ads and things, they have somewhat of a bad reputation, but why is it that we think colonoscopy's got an advantage? And talk a little bit about this perceived downside of colonoscopy.
Sure, yeah. So the nice thing is that whether it's the American Cancer Society, other professional societies related to gastrointestinal care, they provide somewhat of a menu of options. But there are a number of benefits to colonoscopy specifically. The drawback, as you mentioned, is that you have to clean out the colon to have that be effective. But once that part's done, then the benefit is that it is the best test to identify pre-malignant lesions, so things that could become a cancer, and catching them early. But it is really important to emphasize the best screening test is the one that someone actually does. So the order or the recommendation to do a colonoscopy doesn't help if the person isn't able to go, or for whatever is the reason.
Yeah, and I always say any screening is better than no screening. Let's talk a little bit about the risk factors for colorectal cancer, so everybody will know if they have one of those, they need to be a little bit more vigilant.
Sure. So these really fall into two groups. One are some of the red flags that if someone is experiencing these symptoms, that they should get checked out urgently. So those type of things would be noticing blood in their stool, having a change in their bowel habits, having weight loss that's not explained, abdominal pain that they are kind of not sure where that's coming from. Any of those things would be really important to bring up to their doctor so that they can see what's the right way to evaluate that. But those are the types of things that can be signals of a colon cancer or a rectal cancer at that time. The other things are more kind of along the lines of risk factors in the longer term. Probably the most important one is a family history. So if someone has members of their family, whether that's immediate family or extended family, who have been affected by colon or rectal cancer, that's something that could place that individual at higher risk. And so there are adaptations to the guidelines to make sure that special attention are paid to those groups.
And certainly genetics and family history is an important component. And as you know, we have Dr. Kevin Hughes here, who does that kind of work on cancer patients to see who might have a familial risk and to be even more vigilant about their screening. So maybe you could talk a little bit about the colon, and we do have some hereditary forms of colon cancer. And if they do have a higher number of people in their family affected, that might need to get checked out.
That hits the nail on the head. And we've been so fortunate to have Dr. Hughes at the Hollings Cancer Center and develop this program in cancer genetics. And he has enlisted the help of Dr. Colleen Donahue in our group of colon and rectal surgeons. And she's led the way in trying to raise awareness about familial hereditary colon and rectal cancers. So there are some syndromes that can affect folks as young as adolescents to develop colorectal cancer. And so identifying those patients and making sure that they're screened in a timely manner is very important. We've also had some initiatives through the In Our DNA program here in South Carolina to where really just about anybody can get DNA level screening and identify some of these more common mutations that put them at an increased risk of colorectal cancer.
And we are seeing more of these cases in younger folks, as we said, but even people in their 20s or 30s, they probably never thought they would be at risk for colon cancer until they're diagnosed. 2 of these survivors agreed to share their stories, so we'll take a look at that now.
In January of 2022, I was only 36 at the time. My life was totally normal. It's kind of where it all started spiraling. I woke up in the morning feeling like a little bit sick, a little bit of back pain, just kind of off. Literally, as the minutes went by, I started feeling like sicker and sicker to the point where I was like, okay, maybe now I need to take today off work. At that point, I was in pain beyond being able to vocalize what was happening. And so I had the colonoscopy and I woke up, the doctor was there with my husband and he was like, you have cancer.
The symptoms I was experiencing were stomach pains. So I went to the primary care doctor. Basically, he was like, we're not worried about cancer. You're young, you're healthy. I went to the GI, and so she automatically said, well, we're going to set a colonoscopy. But once again, she said, you're young, you're healthy. We don't expect cancer. So I went and did the colonoscopy and got back to the room. The nurse turned the TV on and was like, well, just wait for the doctors to come in. He came in, immediately turned the TV off and was like, you're gonna wanna pay attention for this. So he sits in a chair and he's like, we found a mass and it's definitely cancer.
My whole story changes with Dr. George. One of the things that was really alarming for me was that the first hospital told me that it was only in my colon. Dr. George was very honest that he didn't have that answer for us and that he wasn't going to promise us that that was the case. I think he recognized that I'm younger than most colon cancer patients and I have young children, so his willingness to talk to us was all the reassurance I needed. He explained that the surgery he wanted to do was a risk because they did end up finding a tumor on my liver as well. But they were able to remove all tumors with surgery.
I ended up doing 6 months of chemotherapy, and then they went and did the surgery on the liver and the colon. So as of December 21st, I am cancer-free officially. None detected in my liver or in my colon.
So what do you think are symptoms that patients should think about that relate to colon cancer? I know abdominal pain is always a concern there.
Absolutely. So I think there are some things that that really should raise a red flag. Probably one of the biggest ones is seeing blood in the stool. There's sometimes a tendency to attribute this to hemorrhoids, and in many folks that is the case, but it's something that really should be brought to the attention of a medical professional so that that can be investigated. Other ones really reflect changes over time. So if someone is having difficulty with eating particular foods, if they're become nauseated frequently, if they are having a change in their bowel habits where they're progressively more constipated or even progressively having loose or frequent stools, those are all things that should be checked out. And while they may not necessarily be colon or rectal cancer, it's something that should be investigated, as it could be any number of other things that would benefit from medical attention.
Yeah. You've done some research in looking at the tumor microenvironment, and you found some differences in white patients versus black patients. Can you explain what the tumor microenvironment is and tell us what you found and what it might mean in terms of these different populations?
Sure, I'd love to. It's something that I've really been very fortunate to collaborate with some wonderful folks at the Cancer Center. But what we know is that the development of cancer is really complicated, and that our immune system actually plays an important role in trying to identify these abnormal cells before they can gain a foothold and become a cancer. And our immune system have a number of different cell types, and what we did was we looked at nationally available cancer genomics, where they had identified the gene sequences from cancers across a number of people. And this is a project which is undertaken by the National Cancer Institute. And we looked at the cell types for Black patients and white patients, the cell types that are found around the cancer tissue, and found that there were some key differences. And as to the contribution of those differences to outcomes, I think that's somewhat of an open question. But especially as we've been more sophisticated in our way to target different types of cells, different types of gene and molecular pathways on the way to cancer, it gives us hope that we can catch some of these things early and then maybe intervene in a more tailored way to help people.
Mm-hmm. No, that's very exciting, very interesting.
You've done some really groundbreaking work in the development of colorectal cancer and the way that that fatty tissue impacts the inflammatory milieu and how that inflammatory environment may contribute to the development of colorectal cancer. And this even funded by the Department of Defense and other organizations nationally.
Correct. Yeah, we do have a DoD grant now that supports some of this work. Basically, we've been looking at connections between inflammation and cancer in the gut for a couple of decades now. One of our recent findings is that there is a nuclear receptor in the epithelial cells when people are on a diet that's really high in fat or fatty acids. It actually, some of the fatty acids bind to that receptor and make the cells resistant to undergoing cell death, so they persist longer. And then also it affects proliferation, so those cells grow and have a growth advantage over the normal epithelial cells that don't have that receptor. So we're doing studies in human tissues now to verify that, but clearly in our animal models it contributes to increasing tumor burden. And when we knock out that receptor, we get a marked reduction in the number of the pre-malignant lesions. So it's one of the real clear molecular connections between high fat and colorectal cancer risk.
That really brings us full circle. We kind of led off with the fact that we're seeing colorectal cancer develop in younger and younger patients. And while no one knows for sure, one of the leading theories is that this goes hand in hand with the obesity epidemic, both domestically and internationally, that as we have a larger proportion of the population affected with obesity, that may be partially correlated with the increase in identification of colorectal cancer.
Yeah, I agree. I think that's probably a big component, also worldwide, because we're increasing obesity in a lot of the European and other countries as well. So as we close, I want to emphasize again the importance of colon cancer screening. Colon cancer death rates have essentially been cut in half since the 70s because we have ramped up our screening. It's more effective. We have many more types of screening that we can deploy. Still, colon cancer is the second most common cause of death after lung cancer in men and women. So it's important to get screened. It's important to do that, at the right time frame, and talk to your doctor about whether you might be in one of those high-risk groups that has a genetic predisposition to colon cancer and get screened earlier. Dr. Curran, thank you for being here today and sharing your expertise. I want to thank the audience for tuning in. Hollings Crosstalk is where we connect with the community to share the news that is changing what's possible. And if this is your first time watching, make sure to go to our Crosstalk page to watch past episodes and check out the Hollings news page for our latest updates.